This is FX Radio and I'm Andrew Whitfield-Cook. With me in the studio today is Dr Mark Donohoe, a general practitioner and an integrative medical practitioner of some 30 years' experience. Mark, welcome to the studio. Today we're going to be talking about migraines, but I want to delve a little bit into your history. Tell me about your hospital days.
Well, for my sins, I was one of those doctors who took off in the middle of medicine, did a bit of life experience and then came back and finished it. And that induced a severe punishment in the days of medicine back in those far distant times. For my sins, I was sent to a hospital which now no longer exists called Lidcombe Hospital. And Lidcombe Hospital was basically known as the old person's hospital. Nothing interesting happened there. We looked after people who were aged and got them ready for nursing homes. And rather than it being punishment, it more or less defined my future career. One, I met my future wife there, who introduced me to friends who lived by complementary medicines and not by orthodox medicine. But the other thing was I met registrars there, including one whose whole interest in that hospital was getting people off unnecessary medications. So we would have old people come in, they looked demented, they looked injured, they couldn't get around, they were weak, they were tired, and he had the idea that they were over-medicated. Now at this time we did an average, it was around about 5 to 6 medications on average for this group. And I was of the opinion, having been brought up as a good doctor working in hospitals, that taking people off drugs that they were told that they would be on for the rest of their lives, that this was just dangerous, that you were going to see people die. He had a bit more experience than me and said, no, that's actually not true. A lot of the times the pills accumulate. Doctors give them, forget to take people off, don't reassess them. And we started taking people off their medications. Now, the outcome of that was that about 90% of the people who were coming into hospital for apparent dementia, apparent health problems, could come down to well under half their medications and improved. And some of these should have been obvious to us. People on Valium and Seropax and Rohypnol or any of the drugs that were designed to sedate them. And these were on uppers and downers, anti-blood pressure medications. They'd been on it for years, and as we now know, that leaches nutrients. And so we were seeing people drug damaged, but not in the acute way that doctors pick up. It wasn't a rash. It was the slow accumulation of adverse effects. And Dennis, who is now an ophthalmologist of some renown, he pointed out that we are good at identifying the problems we want to solve with drugs. What we're not good at is stopping the medications and finding out how the person recovers or looking for something simpler to do. So we would discharge these people. The dementia magically disappeared. They were not going to nursing homes. We'd discharge them. They were functional. They were a bit annoyed at their doctors that, they'd been put on all these drugs and had lost their quality of life. But they went back to their normal life. The trouble was that in the time that we were there, they were being readmitted back on the same medications again. What we'd misunderstood was this is just a method in the Lidcombe community whereby people got their parents into nursing homes and inherited the home. And so this was not what we thought. We thought, oh, good, we're solving the problems of this person not needing medications. Until we finally got a GP note coming back on one of the occasions, don't think we don't understand what we're doing. The kids have to get the inheritance happening. The people have to be moved into nursing homes. The medication was a straitjacket being applied to old people so that they would get out of the home and into nursing homes. So the problem was a social one, not a medical one. Drugs were being inappropriately used to shut the oldies up, to stop them being narky, irritating and not wanting to sell their homes and to pass on to the next generation. And that led me to a skill that very few doctors received in their medical education, that is, how do you safely get people off medication? I went to Gosford. The only trick that I had in my practice in an overfilled medical community was I can help you get off your medications safely and effectively. And within a year, my practice was full. And I didn't make a lot of friends with my colleagues there because they would say, you need to be on this for life. People would come off the medications, do very well. And then I had to find, well, what alternatives can you do to control the risks? And that's where complementary and integrative medicine first came into my life, that having to find something that's not a drug is actually not all that hard to do.
Your comments there remind me of a program that I saw on SBS some years ago, and it would be over a decade now. And the comment was, the engine of medicine used to be the health of the patient, and now the engine of medicine is the patent.
Yeah. Well, I think medicine at some point in the last 50 years, within my time actually, probably the last 30 years, has become more self-serving than patient-serving. You can see this evidence-based medicine, the whole focus on statistical medicine, the story of the person's life, the listening to the individual, the finding out what made this particular person sick and what's this particular person's method of recovery, has passed on to, we do statistics on randomized trials, we control the variables, we will tell you what the things are. And so few patients in general practice are randomized. They come in with their own particular set of problems. You spend a while talking to them and you realise they're not the same as every other hypertensive, anxious, depressed kind of person. And when you pay attention to that, there is a whole different spectrum of interventions, approaches that will come forward.
Well, this is a perfect segue into our topic of the day, Mark, and that's talking about migraines. So first of all, can you delve into the signs and symptoms and the differential diagnosis of migraines versus other types of headaches?
It's not actually as clear as everyone makes out. I mean, we say migraines and there is a crossover. It's one of those Venn diagrams where there are people that are absolute classic migraines. They have the aura. It comes on as a one-sided headache. The aura meaning there's usually visual kind of lines, and yes, you get unilateral signs and symptoms. And the headache comes on, typically it takes between 2 hours and 2 or 3 days, and it is pounding in nature, very severe. People tend to go to dark rooms, they're unable to work, and all of these become part of the description of what is a migraine. We differentiate them from tension headaches, but sometimes the differentiation is not all that clear. A severe tension headache most people refer to as a migraine, even if it's bilateral. Some migraines are bilateral, so both sides of the head doesn't exclude a migraine, it's just more commonly starting on one side of the head. It always is associated with disability, and it tends to require analgesia these days and a dark room. And so I suspect what we're going to be talking about today is, well, there's a medical approach. Let's go triptans, or let's go one of the fancy drugs that is able to relieve the pain of migraines. But what else can be done for prevention? What can be done for treatment and the management of it? Treatment and management are very different things. Managing migraines is an art, and we're still putting that picture together. So the migraine, if you ask me, the migraine is a headache that has a trigger. Often there is an aura, but often there is not an aura. And so we have to think, if it's a unilateral headache, it's severe, the person is disabled, that's likely to be a migraine. If they come in large numbers, one after another, and then there's gaps, we tend to call that cluster headaches. And the reason for differentiating them is the triptan medications may work for both, but cluster headaches do respond very well to oxygen. So if people get an oxygen mask, they can often break the cluster headaches, and the cluster headaches are a bit more amenable to relatively non-toxic treatment. Oxygen's toxic if you use too much of it, but at 28 to 32%, it's a very effective treatment. And the tension headaches, far, far more pure association with tension, stress, with lifestyle factors. Some people, it's neck problems, and you can pick those ones because the chiropractors, osteopaths do great work on those where they think it's migraine, but they're not helped so much by migraine preparation, but they are helped by other physical therapies.
And what of acupuncture? I know you're a fan of that.
Yeah, I am. Acupuncture is a very, very potent way of bringing these under control. And funnily enough, some studies show sham acupuncture versus real acupuncture, that there's not much of a differentiation between them, but they're both considerably better than non-acupuncture or no treatment whatsoever. So people find their way through migraines. It may not be precisely by the acupuncture points, but there's something about skin stimulation and penetration with the needles or laser acupuncture that gives people real relief without any drug therapy at all.
And what about an active placebo effect?
Well,
I know that sounds weird, but
no, active placebos.
Stress reduction.
Active placebos are, I think, the big thing in medicine. We have spent 70 years trying to get the placebo out by doing randomized placebo-controlled trials. Yet in trial after trial, placebo treatments in migraine keep on showing way better than doing nothing. So the majority of the response may well be that there's something about a placebo or being in a trial or something where there's active management. And this may go to why sham acupuncture and acupuncture both work. Some attention to it, some belief that this is going to be a benefit actually changes brain and vascular responses so that the measurable responses are not there.
And indeed those same effects would be seen with pharmaceutical preparations as well.
They would be, and they are seen. And we have good studies. We have the brain scans. We know that there are parts of the brain which kind of close down where the blood supply is altered in those situations, and we know that the triptans and other restore that. What we lack is some of the money to do the research in what other non-drug therapies can do exactly the same thing. And we are finding out more and more that neuroinflammation, this kind of constriction, the glial cell constriction, the hibernation of the brain, is an attempt to stop things going wrong. It's not the pathology itself. And so getting control of the next decade of neuroinflammation is going to be one of the big things. And I suspect that's where nutritional, complementary and other approaches are going to really show up positively, something that can allow the brain to restore normal function, where the fatigue, the memory loss, the confusion, disorientation that you see in migraines, they are all part of the way that the brain responds to the migraine attack.
What about the different types of migraines? We know that it's a biphasic response, right? So you get a constriction, then a vasodilatory effect.
You may think we know that. We suspect that, right? And because if you use the term migraine, which we did for a while, back in the late 80s, they tried to divide this down into what are the subtypes of migraines. So the concept was vasoconstriction, vasodilatation, therefore migraine. It probably isn't that. It probably is more to do with trigeminal nerve and the kind of brainstem, little nuclei of the trigeminal nerve, where there's a hypersensitivity response, where the trigeminal becomes super sensitive and stimulus has an impact, and the brain tries to shut that impact down. And in doing so, the migraine is the adverse effect of that sensory hypersensitivity. So people are now trying to explain, well, what's the aura about? Is it really vasodilatation? No evidence for that. Are we just constricting or dilating or fiddling with blood vessels? The evidence is much stronger that it's a central nervous system issue and a brainstem issue rather than all vascular.
So the migraine is a symptom of an issue rather than the issue itself.
Yes, and it may well be an adaptive issue that if you get overloaded in a sensory way, I deal with this all the time with chemically sensitive, light sensitive, sound sensitive people. It has all the hallmarks of a never-ending migraine, those conditions. And the focus has become much more on the trigeminal nerve. The trigeminal nerve is the nerve that is the sensory nerve of the face. It's sometimes called the bad news nerve because the blink reflex, it's stopping you from running into problems. So although we think of smell as olfactory, there's little trigeminal endings in the nose that get the first whiff of a smell and withdraw. So the smelling salts don't require that you smell it.
Yeah.
The smelling salts are the kind of the stress response of the trigeminal saying, something wrong here.
Yep.
Same goes for sound. Loud sound can hit that same area. And the trigeminal keeps on sending stuff back to the brainstem, and if the brainstem's not good at differentiating, messages are getting through that are over responses to the environment around the face and the head and the neck. And so the thinking is, down in the brainstem, there's a sorting problem there, that stimuli that shouldn't cause a problem are causing a problem. And if we could dumb that down a bit or restore normal filtration, that we'd be doing something better for the person. And that's why acupuncture, sham acupuncture, or otherwise even massage can work. You bring new stimulation in from other areas that aren't the trigeminal nerve, and you have now a bit of a competition for normalising those types of things. So I think that there is a whole new area of interest of what do we do with this trigeminal nerve. The trigeminal nerve protects us all the time, but if it becomes overprotective, if it starts to trigger vascular responses or brain shutdowns that are unnecessary, then we have symptoms. No dog or cat or anything can complain about a migraine. They just go quiet and they get over it. But humans know what it feels like, and we look for treatment for something that really is a biological, possibly a protective effect.
So looking into the different types of migraines, from mitochondrial issues to methylation issues and hormonal issues, which are some important areas, how do you differentiate? How do you treat? Tell me more about these types of migraines.
Well, to me, the history is critical. This is where doctors run into a problem, that getting a history of a person about migraines requires that you spend half an hour with them. There are good, clear signs of what type of migraines a person may be suffering. One is if they start early on in life, if they're associated with lactic acidosis, if there is lactic acid buildup in the muscles and it's early on and they're severe and there's no differentiation between the sexes, there are known mitochondrial migraines. We even have a name for it, MELAS, which is basically migraine associated with lactic acidosis. And so those people usually are not going to be the ones that respond to hormonal treatment. Those respond to mitochondrial resuscitation. So with that, you use things like vitamin B2, coenzyme Q10, something to improve electron change transfer and something to aid the mitochondria in adequate energy production. And it's very effective when you do that.
So what about mild exercise in these people to gently increase oxygenation to the tissues?
Exercise is not really well studied, in my view. I don't think it's really well studied. Exercise has lots and lots of benefits, and as you say, oxygenation is one of those benefits. It doesn't help you much with mitochondrial migraines because it induces lactic acidosis, and so you've got to be careful. If the mitochondria are dysfunctional and you up lactic acid, you probably are going to do more to trigger a migraine. In other areas, you might find that there is benefit, but I think migraines related to mitochondria are a very specific condition, and there's good research that shows even just high doses, 400 milligrams of B2, all by itself has a benefit in around about 40 to 45% of those people. If you go a little bit further with mitochondrial resuscitation, every nutritional integrative doctor and integrative practitioner knows what mitochondria need. We get taught about that all the time in bioceuticals seminars and the like. So we go the full hog there and try and give people mitochondrial function back, and sometimes you pass that threshold and the migraines diminish in severity, intensity and frequency. And severity, intensity are the same thing, but they diminish in frequency and intensity, and you can see yourself getting on the right track with that. And paradoxically, what people will say is, and I'm able to exercise more now because my legs don't hurt, my muscles don't hurt. And so there's benefits to be gained by improving activity and reducing migraines in those people.
So is that one of the first presentations of these MELAS sufferers?
No, the first presentation, tragically, in the really severe mitochondrial sufferers is that these things are going on from birth pretty well, and sometimes they're not even compatible with survival. We're talking about the kind of grey area where you've got moderate mitochondrial impairment. It's worth saying this as well. All mitochondria come from mum.
Yeah.
The maternal history is what's critical to this rather than the dad's history for mitochondrial migraines. And mitochondria in the egg cell, there's 400 or 500 of them there, they divide up unevenly. So if you've got, say, 10% of damage, it doesn't divide up 5 and 5 when the eggs first separate. So you get this odd thing where some children will inherit brain mitochondrial defects, others muscular, others in generation of, say, kidney function. So wherever the poor quality mitochondria end up, they keep on going down that cell line and they show up in particular areas of the body. So you can have 3 family members all with mitochondrial disorders inherited from mum, and no 2 of them look similar to each other in any way. For some it's all muscle pain, for some it may be migraine, for some it may be cardiac abnormalities and inability to pump the heart and the blood around efficiently. But it's worth thinking about. If migraines present young and before puberty, think of mitochondrial triggers there. Before puberty, migraines are a little bit more male than female. Come puberty, type 2 of those mitochondrial disorders, which are the hormonally mediated ones, suddenly the female side escalates rapidly, and depending on the type of migraine you're talking about, it can be 3 or even 9 to 1 in favour of females over males. And of course the obvious sign is it's at the same time of the menstrual cycle, time after time after time. So the hint there is not that there's muscle aches and pains, but at the same point in the menstrual cycle the migraines come on. Most people, I would say, it's around the time of menstruation, some a little bit before and some after. But I saw a person just yesterday for whom day 7, 8 and 9 is always the point. It's halfway in that follicular phase where we don't think much is happening with the hormones, but they're building up to the next ovulation. So paying attention to the timing of the migraine, what what I know from people who have been seen for migraines, they don't want to be told, oh, it's like premenstrual syndrome, it's just a hormonal thing. This is not just a hormonal thing, it's that the hormones are initiating an action, a vascular and a brain reaction, which is putting you over that threshold, and the migraine is a consequence. They'll all say, if I'm unstressed, if everything's going well, my periods are fine. Don't tell me it's my periods. But it's just a sign that there is something going on with a hormonal activation of a process. And doing something to manage the hormones is often the way that you get the benefit.
Yeah.
Now that also, as you and everyone listening will know, crosses over with methylation problems, because abnormal methylation is another reason for the migraines, but it's also another reason for the sex hormones not being adequately activated. And so we may be crossing over in all of these areas that people with a bit of mitochondrial defect that wouldn't necessarily be a problem come to menstruation, and now the menstruation and a methylation defect or a methylation low function gene, the combination is enough to push you over the edge. That's before we even look at triggers. These people just go on that way. And then the final one, of course, is that you do get migraines which are purely triggered by a particular agent. It can be a red wine, a young red wine. It can be a particular food, a particular, say, yeast-fermented food or something like that. High amine foods are always the things that we pay a bit of attention to. High histamine foods and drinks also we pay attention to. Mm-hmm. And so if it's never any other time but triggered that way, it is really worth the pursuit of the triggers to see if we can aggregate them for the person. They'll see it as it's red wine and it's blue cheese and these things are not related. And if we can tie them together and say, no, look, there's an amine or a histamine component of those, we may be able to then help a person with diet, with the kinds of triggers in the environment that do that.
So how are migraines traditionally treated with medical treatment, pharmaceutical agents? And tell me about the frustrations with those. I know, for instance, that the opioid issue is a huge issue for pharmacists in the community.
The old way of migraine treatment used to be give them pain relief, put them in a dark room, stop them vomiting. And so it was metoclopramide, which was an anti-vomiting agent. It was your favourite analgesic, which often was, as you say, narcotics. Endone was an absolute classic. Endone is a poor choice. Oxycodone is a highly, highly addictive thing.
You get rebound migraines.
Yeah, and that became our problem, that we could stop a migraine. Then we had the rebound on the other side, and we had the addictive problems. Everything changed a bit while I was, heading through university and a young doctor, where the triptans came along, and we did what we did with Valium and Seropax in the past. We thought, we have the perfect medication, the migraine problem is solved. And there were a couple of professors brought up by the kind of triptan industry to say, yeah, we now no longer have a problem, and these were pushed onto the PBS. And the triptans did have a big impact on a lot of people with migraines. People would take their triptans, and immediately afterwards, 15 minutes later, they were feeling better. Trouble was, sometimes it was happening so quickly that it clearly was not the drug. There was no time for drug absorption, and so there was a strong placebo effect even there, that once you know a drug is going to be effective, the migraines, it's kind of rattle the pack. All you have to do is rattle the pack and you could get the same kind of an effect.
Yeah.
So the triptans transformed what doctors did, and I think we all went to our script pads and just wrote out lots of scripts for triptans. Now, the downside of triptans is they also cause rebound migraines. And so it's good for the occasional migraine, and it's good for the person who suffers, say, no more than 20 a year or maybe 10 a year. They can break a migraine consistently and reasonably well with triptans, and that's a great outcome. And you're not then doing something all the time, giving them a drug all the time. But I have a lot of patients where breaking the triptan cycle is really hard, and trying to stop them from taking just more and more triptans, which trigger off more migraines as soon as they come down, is now probably one of our bigger problems. And you now see the neurologists turning that around to say, look, we've got to go back to simpler, more stable and sustainable ways of treatment. And I think that's where we're stuck at the moment. We know that amitriptyline and anti-nausea drugs and things will work to get control of things. But if the control is not sustained with low and infrequent dose, we have to find plan B.
Yeah.
And plan B is, I think, where the huge interest in complementary and nutritional ways of approaching it, even in prevention. How do you change the environment? There are a lot of my patients for whom fluorescent lighting, the flicker of lighting, is their migraine trigger. You just get them out of that building, or you give different lighting to them, or you put them back in daylight, and they can do the same work as they used to be able to do, but just not in the environment that we put them in. So I think the movement is, we've got a treatment for migraine that's universally successful. It's not. It is partially successful and not sustainable at high usage. And so now we come back to, what are the lifestyle factors, the management, the interventions, what do you do to stop triggers? And that's the hard work of medicine. And when I said you can't do it in a 5, 10 or 15-minute consultation, I'm fair dinkum about that. This is a convoluted story. And if you spend 5 or 10 minutes, you say, I know what that is, because we jump to conclusions early.
So I think this is going to be a big problem moving forward with the future structure of the Medicare system in light of the cuts that are going on.
I know, and the back down. I was hopeful there for a very short while that rewarding consultations over 10 minutes and punishing consultations under 10 minutes was going to be useful. Even our AMA and College of GPs called out for this in the past. But as soon as they heard the word, we're going to save $3 billion, they said, it's coming out of our pockets, no way we will die, rather than let that pass. But doctors, I think, if they're going to, this may sound strange, but if they're going to compete with complementary medicine practitioners, have to learn to care and give time and space for people. And at the moment, to reward 6 minutes is just not time to care. You can't afford to care. There's no time for the conversation and the opening up that's necessary to understand something like a migraine.
So let's go into some of these necessary things that we need to do with migraines.
The necessary interventions to,
things like diet, exercise.
Yeah, from my perspective, the first lot of things to intervene in migraines is try and classify them. If they are definitely hormonal, if they are definitely mitochondrial, if they're definitely methylation, say if you know the methylation genes or the homocysteines raised, there is a technical thing to do first. And in nutritional medicine, we can correct the correctables nice and safely, and often that is enough to diminish the sensitivity to the migraine. So if you reduce a migraine from, say, 5 to 6 times a year down to once a year, people are usually quite happy with that, and they can fall back onto a triptan if they need to, or just take that day off work. I think the starting point for most of these is to also just look at the diet, though. When you have, colours, flavours, preservatives, high amine diets, when people love their red wine, when they get cheap red wine, if they're able to give the story that, when I do these things, I get my migraines, it's always worth a trial of treatment on a diet which is restricted in the histamines and the amines. And it's not hard to do, and if the person gets immediate feedback and reward that they're not triggering it, if they get out of their workplace where the fluorescent lights are triggering migraines, if you can discover from the history a trigger and address the trigger, I think that's by far the most effective healthcare approach, medical or complementary. If you are looking then for what else can we do, going for mitochondrial resuscitation if there's lactic acidosis helps the person in a number of ways and reduces migraines as well. And the kind of cornerstone of proven therapies there, the B2 at 400 milligrams a day and a degree of Q10. You've got to be a bit careful. Q10 can be fairly potent and kind of upregulate those metabolic pathways, but some Q10 in the order of 150 milligrams, those are things worth trying. And when they're effective, people will feel better and have less migraines. For the females who are the majority of our practice where there is migraines related to the hormonal cycle, the job is not to get in and give the pill or anything to disrupt the hormonal cycle. The job is to understand why. And the methylation is one of the reasons that those hormonal cycles struggle around the place. There are plenty of other reasons. But again, I think doctors in integrative medicine and practitioners in complementary medicine do know how to manage hormonally related migraines. And again, the fallback there is vitamin B1, vitamin B6, vitamin B12, and preferably methylfolate, but folinic acid methylfolate. Those are the things that we tend to fall back on. Get the methylation, get the hormonal stability right, stop the stress that goes on every month when they build towards their menstrual or towards the periods, and that is highly effective. More than 60% of people will either eliminate or dramatically reduce their migraines if they're hormonal migraines in that area. Stress reduction is always important, but I tend to agree with some people who say it's not stress reduction, it's management of stress. If stresses escalates,
don't ordinarily go away.
No, stresses don't go away, but whether they affect us or not. So skills of mindfulness, meditation, anything which is able to diminish the impact of stress on the person tends to diminish the frequency of a whole range of different disorders, but migraine is especially vulnerable to stress reduction. If you get the stresses under control, migraines will normally be reduced. Now, that is a pain to say to a person because they will say, the migraine is my stress. I am stressed because I get migraines. But you can still work on mindfulness, that idea of letting the things go past and not fearing and not focusing on what's coming next. Living in the present does really, really good work for us as well. So I think those are the starting points. Then we get into complex things of diet. I have a favourite, which is what kind of red wine triggers your migraines. People normally are surprised that 8-10-year-old red wines do not. The histamines, the amines, the sulfates are incorporated by the tannins in those wines. Part of the value of aging is not the mellowing of wine, it's that it is now not full of those agents that trigger the same response. Red champagne's always good, but it's not exactly the number one treatment for these types of things. But red champagne, again, no sulfates. But
maybe a choice rather than a...
That's right. If you're going for something, you may as well go for the good red wine and the French champagne because they lack the components that otherwise can trigger these kind of migraine responses. So these are, lifestyle choices. You can then choose your practitioners. I think that the yoga and mindfulness, those kind of practitioners have a lot to offer. Not because it's a specific treatment, but because the triggering requires that the circumstances be right and the reduction of the response to stress is important.
So foods to avoid, avocados, cheeses.
Yeah, I think you can get the list of the high amine foods and the high histamine foods. The foods that will trigger any histamine response, we have to be careful also of allergic people where there is naturally high circulating histamine around the place. Funnily enough, antihistamines don't work well, but there are a new class of H3 receptors, H3 and H4. So there are histamine 3 and histamine 4 receptors in the brain, and the new class of H3 receptors that are coming on board tend to settle these kind of hypovascular responses. So there is probably in the future medications that will be able to do it. Now that the research has started into the H3 receptors and its part in neuroinflammation and these vascular responses, hopefully we'll get complementary therapies that have probably always been doing it. The RG3, the ginkgosides and ginsenosides, and many of these things are truly acting holistically on the whole of the brain. Medicine catches up by finding a new receptor every so often and saying, oh, now it makes sense. But it didn't before. So it was wrong before we had evidence, but now we have an H3 receptor. That's evidence, and now it's okay to use it.
At least they're calling it a histamine receptor now, rather than the old days. Forgive me, a GABA receptor in the old days was called a benzodiazepine receptor.
Yeah, and it's like we're benzodiazepine deficient. You must remember, in my years at uni, we had in 1974, I'm going to say 1975, we had a professor say, look, we found the perfect drug. Benzodiazepines have no addictive effects, no dependency, there's no dosage building, and he's comparing them to the previous drugs that were potentially fatal. Comparatively, they were better. But what's our biggest drug problem in Australia right now? Getting people off those very drugs that we said had no adverse effects or addiction.
What about magnesium to try and dampen the effect with the NMDA receptor?
Yeah, so you're right. Magnesium has got so many beneficial effects. I mean, I realise now that in my clinical consultations, when I'm not sure what's happening at the end, and I've got to say, well, what can I do? Probiotics and magnesium are the two things that I say the potential downsides of these are so low, and while we find out from the pathology and from other tests what's going on, give it a try. The downside of that is so many people come back and say, I don't need to see you anymore because the magnesium's worked or the probiotics have worked. But the upside is they do something to hold the energy, so the mitochondrial cycle, they do benefits in the hormonal cycle. The magnesium is a muscle relaxant, so when it comes to stress and the vascular responses, it just has so many different actions. And I think the biggest problem for us as practitioners is we underdose, that when we're giving a trial of treatment, we should be talking about 300 to 600 or even 800 milligrams of elemental magnesium as the trial of treatment. And so many times people say, I've had magnesium, and you look at the bottle and there's 40, 50, 80 milligrams there. It's unlikely to have a big impact on a disease state, such as migraine. It's likely only to be of general benefit at those doses. So trial of low-dose magnesium and a decent dose of CoQ10, they're really, really worthwhile in all of these cases.
The form of magnesium that's really got a name in the market for treating or helping people with migraines is the magnesium diglycinate because of its absorption characteristics, and you're able to use higher doses. But long term, would you consider changing to something like an orotate, maybe to help the mitochondrial aspect?
Yeah, the orotate's really interesting, isn't it? We think of the elemental magnesium dose as the critical thing, but the orotic acid has got an ability to bypass some of the defects in the mitochondria. And so the magnesium orotate, where you're really only getting, say, 100 or 150 milligrams of magnesium, delivers orotic acid at a much, much higher dose. And there are alternate energy pathways. The uridine pathways are really important. So the orotic acid's ability to convert and participate in alternate energy pathways is really critical. So magnesium orotate, if you think that there's a mitochondrial component, I would say that the magnesium orotate is the orotate of choice.
So after resuscitation, you use your orotates.
And that's a maintainable thing. You're not going to get any problems. The dosage doesn't have to be all that high. And the orotic acid is a very, very well-handled nutrient, not a nutrient, but a very well-handled metabolic product of the mitochondria that's used for the uridine synthesis.
What about the use of IV magnesium in the acute stage?
I have never used IV magnesium for migraines, but you have to understand my practice is not one where I see people with acute migraines. I do have plenty of patients who use the magnesium sulfate intramuscularly, and you know that is effective on a biological level because the pain of the injection is extreme. People self-administer, say, half an ampule, a couple of mils of the magnesium sulfate in order to get relief within minutes.
Deep IM?
Yeah. It's a very painful injection. The ampules are available easily, but you know that people are getting the benefit because there is no placebo side to this. They put up with the one pain to immediately get rid of the other. Yeah. And so for the people who are highly magnesium dependent, there is this concept of channelopathies when you get to fatigue and migraine syndromes. What does that mean? Well, magnesium and potassium are intracellular, and calcium and sodium are extracellular generally, and it's the exchange that results in normal successful nerve and muscle transmission. A channelopathy is a leak of potassium or magnesium out of the cells, a perpetual loss so that there is a deficiency of one or the other, and the cells become very unstable. They become hyperpolarized. If you can get the magnesium in by brute force, or preferably by the magnesium orotate, you can undo the magnesium side. Occasionally you forget the potassium. And that if the magnesium doesn't work, a surprising number of people do well on a good potassium. And so there was, in the old days, good high doses of potassium magnesium aspartates. Aspartates maybe not the best transporter, but it was okay. And so you could get people who could cover both bases and then figure out which it was at a later date. But from my perspective in practice, successful oral magnesium resuscitation is one of the best things that we can try, and the number of downsides is very rare. Occasionally you find a person who's high in magnesium who just gets tireder, but that's a small price to pay compared to the number who get a lot better. What
about mindfulness, sleep, and of course one of your favourites, acupuncture?
Yeah, I tend to refer off for all of those. I'm not that mindful a doctor. I am married to a mindfulness educator, and the first time I tried it after 25 years of being with her was at a conference where she was doing it to the audience. And I thought, why did I not pay attention to that 25 years ago? What have I been missing all this time? But like the typical doctor, I go back to work and still don't pay attention to it 6 months later. But the power of it is that it's a good alternative to this rotten cognitive behavioural therapy. The CBT approach became anything a doctor wanted it to be, and half the time it was, hey, grow up and get over it. That was basically cognitive behavioural therapy for the typical GP. Nothing subtle. It was just, if you talk yourself out of it, you won't have this anymore. Right. And it was like a parent talking to you saying, if you don't do X, you won't get pocket money. Yes, okay, I'll do X.
So what's the mindfulness approach?
The mindfulness approach is not to focus on the symptoms to talk yourself out of it, but to allow them to pass over without the added complications of the fear, the doubt, the is this going to end. It's a return to the moment which allows for the sensation to be just the sensation, so not to be the signal of a future disaster.
So bending like a reed in the wind.
Well, that's a very good way. I'm sure my wife would say that. But Fiona's approach has been very successful in people who I am unable to treat in other ways. And so the missing factor for me is often, if you can't get the kind of pharmacological approaches getting you to the other side of that migraine, there's additional things which are very safe, very effective, and do you good in the whole of life. Yoga, stretching, movement, and mindfulness. I don't think anyone's actually going to suggest that there's any harm to come from any of those skills.
Lastly, Mark, let's just talk a little bit about some of the caveats or the warnings that you might be suspect of when you're seeing migraines. For instance, somebody who might be suffering celiac disease. How much further do you look? What are the red flags you look for?
Well, there's a couple of things. First of all, there are true other medical conditions. So unilateral headaches, we do have to think of other vascular events. We still have to think of microstrokes. So there are times, and this is why GPs have been given the ability to do MRIs on changing headaches where you expect there could be something inside the skull. The very reason is little berry aneurysms, microstrokes, lactic acidosis affecting the brain give particular signals that we can identify. I think I'm also finding a couple of MRIs now, they're doing the spectroscopy, and the spectroscopy is very useful. The choline signal telling us that there's neuroinflammation there. This is not, encephalitis in the normal sense where you're going to die. It's the brain shutting down nutrient delivery to parts of the brain. The glial cells closing off saying, hey, something's wrong here, let's shrink down. And so the paradox is inflammation in the brain shrinks the grey matter, inflammation all the rest of the body has the immune cells enter and then cause all kinds of trouble. So we are finding that there is intracranial pathology that we've got to make sure is not causing the problems. It's a big miss to miss, microstrokes or berry aneurysms because you've just anticipated it's a migraine. So paying attention, if you've got aura, classic migraine, you can be pretty sure that's not it. If you've got atypical migraines, it's always worth doing the MRI. Beyond that, there are other things, rarely meningitis, but usually a migraine history means it's not meningitis and there's no true encephalitis, but always stretching the neck, pain that's induced or classical migraine that's caused by neck movement has to be thought of as potentially a meningeal irritation. So I think we can go through that relatively quickly in the medical history. When it comes, what's the ultimate cause of the migraine? That's a very different question. So all we've talked about today is what do you do for migraine in isolation? How do you know it's migraine? What do you do for intervention? Why is there migraine? The celiac genetics and the celiac type of effects of leaky gut and the opening up of the blood-brain barrier and the triggering of the kind of vascular responses inside the brain, that's a whole different story. I think it's always sensible to just know what the celiac genetics are like, to have a look at the gut. So many people get their migraines better with probiotics that it is clearly a relationship with the gut as well. So when the gut improves, the migraines are triggered far, far less frequently.
I think what's going to be interesting is to hear Dr. Catherine Wilner and Mike Ash talking about the gut and neuroinflammation at the 2015 symposium.
Yeah, those two things are very related. And it's what I think is exciting about this new one. The masterclass is not just that you've got four people with different ideas. It's the integration of those ones. What's in the gut, what's going on in the brain, what's going on in the cardiovascular system, nutritionally, what's going on. If we could tie those together, I would say that if we got the neuroinflammatory responses and the gut right, if we had better answers for that, and that's what I'm really anticipating from the seminar, from the symposium, if we get that right, we'll have practical ways of going out and fixing people on Monday the weekend, after the weekend. And that idea of translating good researchers and good theory and getting a practical outcome is very exciting for me.
Dr. Mark Donohoe, thanks so much for taking us through what can be a very frustrating condition for both practitioner and patient. We've learnt that migraines may be a symptom of neuroinflammation and that it's worth delving into the different types. And to differentiate which type of migraine will help the practitioner choose which therapy to advocate. We can effectively use safe therapies like mindfulness and yoga to reduce frequency and severity, and that supplemental use of several of the B vitamins, B1, B2, B6, B12, the various types of folates that are on the market, and possibly even some of the choline, phosphatidylserine, things like that. But also things like coenzyme Q10 and magnesium can be of benefit in several types of the migraines. Yeah. And can also help to reduce the drug issues such as rebound, migraine and headache, and also the addiction area. So thank you for taking us through that.
It's been a pleasure, as usual.
This is FX Radio. I'm Andrew Whitfield-Cook.